Welcome, welcome. Hello. Thank you for joining us at today's edition of the Advocacy Exchange. It's great to be here with you, as always. Thank you for making the time, as we're still adding lots of people, lots of wonderful fellow advocates. And it is much appreciated that you're making the time to be with us today at the Advocacy Exchange. It is always a delight to be in collaboration with you about making the future of healthcare. For those I haven't met yet, I'm Brad Love. I'm one of the Gryt co-founders and a health outcomes researcher, and just really thrilled to be with you today, thinking about the absolutely essential topic about the finances of healthcare and about simply the idea that well-being and healthcare goes beyond managing physical health, that the economics of it are an absolutely essential category, but perhaps one we don't talk about quite often enough. So that's why we're diving in today with a couple excellent panelists who are experts in this space, and will be able to recommend some resources and help build your organizational capacity to work on continued financial issues. So thank you for making the time, and thank you for what you do every day as an advocate to help make healthcare better around the world. Also, in addition to today's session, I would like to take a minute to point out, if you haven't had a chance yet, to check out our global virtual cancer conference site, gvcc22.com, that it's another resource that we're eager to bring with you as a collaboration between Gryt and BMS to share a range of absolutely essential, authentic conversations. And so we'll have recordings of those come online in the coming weeks. But I can tell you, as someone who had the good fortune to attend live, those were some of the most special conversations I've ever heard about authentic and real experiences in the challenges and also the joys of sharing a healthcare journey. So we'll continue to share resources about that as the videos come online. I'd also like to point out, for today's conversation, we are again fortunate to have two ASL interpreters, Mackenzie Velez and Emily Cook, who you can pin by clicking on the three dots next to their names. And we thank them for spending time with us today and helping include more voices in the conversation. You can also see their names in the chat. To get things going and think about our conversation about financial resources and medical costs, we also have a quick poll question that we'd like to use to check in a little bit to see where our audience is today. You should see a poll pop up at the moment that says, how aware were you that there are financial resources available for medical costs and everyday expenses? If you're in a place to do so, we'd love to see what kind of answers you all have, and that can give us some foundation to kick off our conversation in just 1 minute. And we'll see what kind of results pop up as we're being patient with that. We know for sure there are different knowledge levels and different experiences with that. But regardless of the healthcare system that you're in around the world and how well supported it might be, there are also so many other financial challenges to illness to think about, the adjunct costs around issues of transportation and the small challenges that come up. And our two guests today can help us think about this and bring some resources to bear. And seeing the poll results, okay, 70% somewhat aware, and that's great. We're going to get you into the very aware category today, I hope, if nothing else, with the links to today's guests and some of the insights about what it is they do. So with that, to dig into the absolutely essential knowledge and complexity of this experience, I'd like to ask each of our guests to introduce themselves, starting with Amy Niles from the Pan Foundation. Thank you for being here, and thank you for sharing your wisdom with us. Would you mind sharing a little bit about where you come from and what brought you here today?
Thank you so much, Brad. I'm really happy to be here today for such an important conversation. I want to thank also the Advocacy Exchange and Gryt Health for inviting me today. I'm Amy Niles. I'm Chief Advocacy and Engagement Officer for a charitable foundation called the Patient Access Network Foundation. Most people know us as the Pan Foundation. We are a not-for-profit patient advocacy organization, and at its core, we provide financial assistance to people who have insurance, but they're underinsured. And this financial assistance helps them cover the out-of-pocket costs for their prescription medications, which, as we all know, those out-of-pocket costs can be really high. We've been at this mission now since 2004. Since that time, we've helped more than 1 million people access the medications they need. We've provided, and this is a big number, $4 billion in financial assistance. It's big because the out-of-pocket costs are so big for often very expensive medications. Personally, I've been in the business of helping patients my entire career. Honestly, I find it unacceptable that in the United States, with so many medical advances, far too many people, even people who have insurance, cannot access the treatment they need. And it's why I've spent the last 15 years really advocating for improved access for care for all people. We know that affording prescription medications is a very big piece of the affordability puzzle. It's just one piece, though. There's many other factors that impede access, but when it comes to prescription medications, I guess my goal is to make sure that 1 out of every 3 Americans are not walking away from the pharmacy counter like they are today because they can't afford their medications.
We are also incredibly fortunate to have a guest from Family Reach, Chris Strumfels, who is doing similar amazing work, thinking about the finances of healthcare. Hi, Chris. Thank you for joining us. And could you share a little bit about what brought you here in your work?
Thank you so much for having me. I'm really excited for our conversation this morning. My name is Chris Strumfels, he, him, and I'm a resource navigator at Family Reach. I'm also a licensed social worker here in Massachusetts, and I've been working at Family Reach for over 2 years now. After joining the organization after graduating from Boston University School of Social Work in 2020. I'm also a steering committee member for Boston Liberation Health, which is an organization of social service providers and users dedicated to speaking about and teaching the Liberation Health framework. And like Amy, I was really drawn to this work because of how passionately I feel about the system that we have in place that forces families to make these really unfair and awful decisions regarding their finances once they're already dealing with a cancer diagnosis. And I believe very strongly in being part of an organization that understands that is an area of critical need for folks across the country. Family Reach as an organization has been around for many years now. It was initially started as a small regional nonprofit by 2 families that had both lost a loved one due to cancer. And we now work with families and social workers across the country. I'm primarily involved with delivering our financial treatment program, which is working very closely with families and patients. And I will say a little more about what is involved in the financial treatment program later. But it is specifically geared towards addressing this financial aspect of a cancer diagnosis. And again, very happy to be here and very excited for this conversation. Thank you.
So often something that doesn't come up, especially in clinical practice, where the focus is understandably, and for excellent reasons, of course, on treatment, but not necessarily including the financial implications. And so being aware that the PAN Foundation and Family Reach both do an excellent job of educating and supporting patients, especially about financial resources, I'd like to ask each of you to describe a little bit, to map out the narrative so we can really understand some of the complexity about how the financial aspects and smoothing them out can improve outcomes. Amy, could we start with you? I see that you're unmuted.
First, I'd just like to say that Family Reach is a fabulous organization, and I'm so honored to be here with Chris today. Health literacy is such an important topic, and to say that our healthcare system and the language that we use around affordability and health insurance is complicated is an understatement. If you just think about the words that we use every single day, we have copays, we have deductibles, we have coinsurance. In the Medicare program. We have Part A, Part B, Part C, Part D. You have words like formularies and specialty tiers where the prescription drugs are sitting, and depending on what specialty tier that is, someone may experience higher cost sharing for their medication. You have words like catastrophic phase of a Medicare benefit. You have words like copay accumulators, which has become a very common term. These are policies and programs that so many plans are instituting that, by the way, most patients don't even know about. And this is, for the most part, affecting people with commercial insurance. And these policies are preventing access to needed medication. So it is extraordinarily hard for any of us to figure it all out. But I think at the end of the day, all of us at PAN, I'm sure all of us at Family Reach, believe that someone with a serious illness like cancer should be focusing on their health and shouldn't be focusing on how they're going to afford their care. But, you know, we know that that is easier said than done. So I just want to share a few things that I think are important to keep in mind. Everyone, and this is hard too, and I get it, but everyone needs to be their own advocate. They need to ask questions, they need to conduct their own research, and they need to know that there actually are resources out there to help them. Organizations like PAN, organizations like Family Reach provide a whole lot of resources. We have people who, you know, are talking to patients every single day. So we are here to help. There are lots of other great organizations as well. You know, two come to mind. One is Triage Cancer, who's, you know, they provide great resources for practical issues that people with serious illness like cancer are living with every day. And of course, you have the Cancer Support Community, another national organization that's there to support people living with cancer. But one thing that I want to stress is that, you know, we know that healthcare providers, and that includes the pharmacists, are trusted sources of information for many people. No one should shy away from expressing concern about their ability or inability to afford their care, prescriptions or otherwise. It is a very hard conversation to have, but I think it's an important conversation to have. So, for example, if a provider prescribes a medication that, you know, is going to be effective for you, but it comes with a high price tag, patient can have this conversation and ask, is there another equally effective medication that might come with a lower cost? Now, there may not be, okay, but it's important to just have that conversation. Additionally, the staff in the provider's office are key resources for patients, and especially in the hospital, people who are patient navigators, financial navigators, are really in a unique position to connect people with needed resources. Another thing is to take advantage of the open enrollment period, which is happening, you know, right now. One really needs to do research. Again, sometimes easier said than done, to find a plan that meets your current medical needs and is affordable. But you have to do the research and have to ask questions. You have to look into, you know, what certain plans are going to cost. Is your medication covered? What tier is it on? Is your provider in network? Are there situations where prior authorizations are going to be needed, and so forth? There's a lot of questions that people should be asking when looking for their plans. And also take advantage of other programs. You know, for Medicare beneficiaries, there are great resources, including Medicare.gov, including the National Council on Aging. So I think the bottom line for me in terms of all of this is that if someone is empowered to ask the right questions, to search for more resources, the bottom line is that it will improve their care. If they can get connected to needed resources that removes these barriers, at the end of the day, they can start and stay on treatment. And that's always a good thing.
Without a doubt, access is part of every dialogue we have here at TAE. Chris, could I turn the same question over to you? in your work, how do you see the connection between financial resources and outcomes?
To start, I just want to say again, I'm so thrilled that we get to have this conversation together, Amy, because without us reaching out, we really did hit on some very similar themes. I mean, it goes to show you how prevalent this issue really is. So just to start, I think it is again worth stating and stressing that it's absolutely true that there's a direct correlation between, financial distress and health outcomes. And this is true when it comes to a whole range of health issues, not just cancer. And so I think it sometimes can be easy to overlook just what a tremendous difference real material support can make when it comes to health, which to me always brings up these two different studies that always are sort of like in my mind as I'm thinking about this issue. And the first is pretty commonly known. It's just that there's a long and well-documented relationship between health outcomes and financial stress that show they're inextricably linked when it comes to cancer diagnoses. That when you aren't dealing with the stress of that financial distress, your health outcomes are generally always going to be more positive, are going to be closer to recovery. And the second isn't related to cancer, but it's a study I think about pretty often, and it came out during the pandemic. And it's especially interesting to me as a social worker because it was basically a study where they were studying changes to patient mental health when they were given access to just funds, when they were given access to psychotherapy, and when they were given access to funds and psychotherapy. And across the board, what made the biggest difference in patient mental health was just having the money, was just having the funds. So I know that's not directly related to cancer, but I think it's a great example of how material support really sometimes is kind of the most significant impact you can deliver for families for a whole range of health issues. But beyond that, like we've shared, education and financial literacy is also deeply, deeply important. And one of the ways that I found really helps in this arena, and it's something all of my colleagues do at Family Reach, is to really take time to acknowledge how difficult it is to have those conversations about financial distress, like Amy was saying about trying to be your own advocate, because it can be extraordinarily difficult to actually say that you need assistance and to try and find partners who are going to be able to help you secure what you need, even if it is your social worker at your place of care whose job is to help you out in whatever aspect you need. So I've had countless conversations with families that just start by letting them know that this isn't something to feel ashamed about, that this is something that's happening across the country, that it's a conversation I have with almost every family that I get on the phone with. And just because they're looking for help doesn't mean that they had done anything wrong or had been irresponsible with their money. I think it's just so important to acknowledge that all of us are immersed in a culture with the dominant worldview messages that tell us that poverty is reflective of some kind of individual failure or even a moral failure. And all of us here know that that simply is not true. So I find it so important to address this first with families whenever possible, because that's really, I think, the first step to helping families become their own advocates and start to navigate the really, really messy, sprawling systems that we have here for that kind of assistance, is to just acknowledge that because they're asking for help doesn't mean that they had done something wrong. It's because we have a system that's failing them. And so once we're grounded in this, I try to work as closely with families as possible to just let them know how I go about finding resources. And again, to be honest, it's really just utilizing search engines. It's finding out about organizations like PAN, about the others that Amy mentioned that do a wonderful job of trying to find and get access to these resources for families. And again, just encouraging them to speak with social workers, especially at their place of care, who are going to be really the experts, especially on local resources, of which there are many, many, many. And of course, the many public resources that are now available. Especially in the wake of the COVID-19 pandemic, there's been a whole host of new public resources that are available when it comes to things like housing, utilities, that weren't available before, and that can be really tricky also to navigate. But I'm really excited the extent to which, Amy, you and I are definitely syncing up. I mean, when you're in this field for long enough, you're going to hit upon the same issues again and again.
Your comment about not being ashamed resonates always, but really resonated because, we do so much support for people on Medicare. And when you think of I don't like to use the word average, but the average Medicare beneficiary, they have a fixed income of around $28,000 a year, out of which they need to pay rent, mortgage, pay for their food, pay for their utilities. Oh, and then on top of that, they have to maybe pay $10,000 or more in out-of-pocket costs for their medications. And that's just the medications alone. No one can afford that, even people who are not on fixed incomes. So I think you're right, the healthcare system is very broken, and you know, hopefully we'll eat away at some reforms that are needed to improve it.
Absolutely. And as Candace is wonderfully pointing out in the chat, and Chris, as something you just mentioned, that all this starts with helping people maintain dignity. Without that, we're not doing healthcare. We're just offering treatments. And those are very different things. It's not helping people thrive if we don't start from, as Candace puts it, empathy and respect. And to think about that a little, you know, Chris, as you wonderfully mentioned, and I say this to the 40 advocates on the call to help make this a thing we all say out loud, to remind people that asking for help is a normal thing. It doesn't make it easy, we can all agree, but it is a normal thing because we're people who live in community and we have needs. And so one of the things we can all do as advocates is receive that well when people say it, but also help them say it at times, which I know can often be, Chris, as you were saying, a big part of being a social worker.
Absolutely. I mean, just as a small example of a family I worked with last week, I just they had sent in an application through our website, and part of what we normally do, I reached out to the social worker they had listed, and I said, hey, this family just reached out looking for some assistance, and the social worker was like, I had no idea that they were even like at a point where they felt like they needed to like reach out for stuff. So even if you are a social worker who's working really closely with families, it's just part of what's so important, I think, to be proactive about bringing this up for folks, because she was really like, I did not know they were applying to your organization. I didn't know they knew about your organization. I didn't know they needed assistance with rent. And it started, now they're able to check in more frequently about finances. But it can be so hard to start that conversation, but it is so essential.
And for any health issue, right, something for us to think about in terms of advocates and the kinds of resources everyone can make in their own domain is helping give people in our community scripts and language to disclose challenges. Disclosure is such a challenge in all contexts. How do I disclose a diagnosis? How do I disclose the need for help? It is just a challenge as a human. So it seems like then a wonderful time to move to some resources. Let's capacity build among all of our attendees and future viewership of this session. And so if I could ask you to incredibly shamelessly plug, do some wonderful PR for your organization's resources, because they're things that help people and they're wonderful. I'm saying they're wonderful. You can maintain some humility. But if we could start, Amy, with Pan Foundation, could we talk about things like your fund finder and other resources you have to improve access to financial assistance for treatment?
I'm very happy to talk about Fund Finder, all that we do, and to plug PAN, because we want as many people as possible to know that there are resources not only at PAN, but at other charitable foundations. So at PAN right now, we have around 70 or so programs that provide financial assistance for people who are seriously ill, living with chronic conditions, living with rare diseases. And I think around 23 or 24 of those programs are for people living with cancer. So many different cancers are addressed. Most of our programs, but not all, support people on Medicare. And that, one reason why that is so, one, they have tremendous need, but two, we serve a very important safety net for them, because if you have federal insurance, you can't seek assistance directly from a manufacturer. So this is why charities like PAN are really such an important resource if one has federal insurance. If you meet our eligibility criteria, which are fairly similar across the board, and that's, you have a particular disease, you're looking for a particular medication that is on our covered list of drugs, and that's all published on our website. You are living in the United States or one of our territories, your income is up to 400 or 500% of the federal poverty level. And no one knows what federal poverty level is, but for example, 400% federal poverty level is about $27,000 for a family of two. And you have insurance, then you can receive a grant that will cover most of your, if not all, out-of-pocket costs for a 12-month period. So for example, we have one program that supports people living with chronic lymphocytic leukemia, commonly referred to as CLL. It's for Medicare beneficiaries. If you meet the eligibility criteria, you can receive a grant of $9,300 for a 12-month period. So we have done surveys every single year of our patient population and of our providers, and year after year, what we find is that without assistance, people more than 4 times a year, 5 times a year are foregoing their medications, or maybe they're doing things like splitting pills in half to make their medications last longer because of affordability issues. Once they receive assistance from PAN and likely any other charity, that the medication adherence skyrockets. They're able to stay on treatment. So we know that the work that we do is impactful. What I know is frustrating for many people is that many of our programs, what we call open and close several times a year, and that's just related to having the funds available through contributions to provide grants. So if a program, and we're transparent on our website so one can see what programs are open, what's closed. If it's open, we have funding to give out. If it's closed, at the present time, we don't, but we hope to reopen that fund soon. If a program is closed, I always say, sign up for our wait list, because when the funds become available, we'll open up our wait list first for people who need that assistance, and then we'll open it up to the public. But Brad, you mentioned Fund Finder. So we are one of 9 national programs that provide copay assistance. Of the 9, there's 6 that are in what's called independent charitable foundations like PAN. And then the other 3 are patient groups that do a lot more than copay. So for example, the Leukemia and Lymphoma Society is one such organization. But between the 9 national organizations, we operate 200 plus patient assistance programs. So can you imagine, as a patient or maybe a provider, first you got to know what are the organizations providing copay assistance. Then are you going to call them every day or to find out who has available funding? Are you going to visit 9 websites every single day? So we, 3 years ago, we launched a very unique program. It's a web app called Fund Finder, where through technology, we're able to bring all of these programs together in one place. And it's updated every single hour. That's how frequently availability can change. So I'm going to use CLL again as an example. 5 of the foundations, 5 out of 9, do operate programs that offer assistance in CLL. Today, 3 of them are open. PAN is one of them. Let's just say, for argument's sake, all of us were closed. We didn't have funding today. If one had registered for Fund Finder, and that's a simple process at fundfinder.org, and you express interest in CLL, we're all closed today, but let's say tomorrow PAN opens, we can give out grants. You'd receive a text or an email tomorrow that says PAN Foundation is open. That will alert you right away, and we encourage people to do this right away because funding can move out pretty quickly. It will alert you to go online or call us and get assistance. So we have so many users of this app, and we know that it is saving time, and likely it's saving lives as well. So I do encourage everyone who's listening today to register for it. It's a terrific program.
Okay, thank you immensely for that. And a quick follow-up from one of our community members, Kathleen, who I think you answered the first question, but Kathleen, please respond in the chat about if an organization can sign up to get notified when funds for a disease site opens. It seems like yes.
Yes.
Per that. And very thoughtfully, again, hugely appreciate, Kathleen, your consideration for other people in not wanting to send people to closed sites, because that's just wasteful emotional labor that nobody needs. And thinking about, okay, a wonderful privacy question, I think, Amy, about how to consider, as you might be able to see in the chat, the concern about giving people's federal ID numbers online, because that can be scary for people who are already vulnerable within society. And I'm curious, I guess maybe a better way to ask this is, what does data privacy look like for these things, to the best of your knowledge? I realize that's not your domain exactly.
We take data privacy very seriously. We have a very strong compliance program at PAN. So people need to be assured that the information, and we don't ask for much, the information that we collect through our call center or online is secure. We're not selling it to anybody. Through the regulations that we adhere to, we're not providing it to any other organization or our donors. So I think people should feel assured that we take that very seriously.
That is beautiful to know on behalf of everybody, because that is so essential, especially for
Yes.
people from historically marginalized groups.
Agreed.
And Chris, could we pass over to you to ask the similar question of where we started from, about asking you to do some wonderful PR, shamelessly, because they're beautiful, important programs, for things like financial treatment program, financial guidebook, and all of the essential work that happens over at Family Reach.
Absolutely. But, before I'll finish up some PR for Amy and just say, the work that PAN does to make it possible to navigate the labyrinth that is trying to find resources for folks is essential, really. I don't know how any folks in this space are really able to do this work without organizations like yours that make it possible. So again, to finish up a little PR for you, yeah, absolutely essential work. But for what I do, sort of day to day at Family Reach is delivering our financial treatment program, which consists of what we call our 4 pillars, which are our financial guidebooks, financial coaching, resource navigation, and emergency relief grants. And so the financial guidebooks are sent to every family who reaches out and applies. These contain a bevy of information about the greater context of the financial impact of a cancer diagnosis, about the largest, most common resources that families can begin to explore on their own or with their social workers, some advice or information about how to go about navigating these changes in your budget, and just more information that if I was going to spend all my time here talking about, I wouldn't get to the other pillars. But it's a way to get started to understanding this whole monolith of things you're going to have to navigate now, and to get used to sort of break the ice for this, because it can seem impenetrable when you're first diving into it. We also offer up free financial coaching with a certified financial planner for families who are interested. We're able to link them up with someone who they'll speak with and meet with several times to discuss their overall financial situation, their greatest needs, and things they can do to try and manage the many changes in their situation. With resource navigation, I got to touch on that a little bit before, but generally, once I'm able to review a family's general situation through their application or speak with them or their social worker, I will try to find some resources that can help with their stated needs, whether it's through diagnosis-specific organizations, local organizations, state or federal programs, other nonprofits that are focused on medical costs, for example, or any other needs that might have popped up or that the family discussed. So this can really be a whole range of things. I can say an example that always pops to mind for me was I'd been speaking with a family about their application, and we were talking about housing needs, and just through our conversation, I was talking about their housing situation. They mentioned the primary reason they're looking for help right now is because they just discovered mold in their household. And obviously their child with a cancer diagnosis couldn't be staying there in that situation. And so on the phone together, we just ended up using search engines, Google, whatever, to try and find a company that would be able to start with their actual mold removal process. We were talking and they were feeling so overwhelmed. So I don't even know where to start. And I said, well, we can start, right here, right now. So resource navigation can look like many, many different things. And then we have our emergency relief grants, which are grants of the max amount changes often, but typically right now it's around $1,000. We're able to distribute through checks either directly to vendors such as landlords or utility companies or banks, or directly to the families themselves. We also partner with a number of smaller nonprofits throughout the country in order to provide similar resources, especially in the form of grants for families. And sizes for those can range greatly. We also have deep need grants, which can get up to $5,000 plus dollars for families. So we have a lot of flexibility, we have a lot of options. But again, I think it also reflects the extent to which it really is a labyrinth to try and navigate these things, because there are so many different programs and organizations out there. And I also say that what our financial treatment program looks like today, this is what it looks like, but and something I'm really proud of about Family Reach actually is that we're always evolving, we're always changing, we're always adjusting based off data to ensure that what we're delivering is actually what's most needed and most appropriate for families and patients. So this is what we do today, but it may not be exactly what we do 1 year from now. But I do know that the core of this program, which is our ability to provide, direct relief and also help patients and service providers have the tools and resources to meet further needs over a longer period of time, that will always be at the heart of what we're doing in our financial treatment program. So it may not be the same. I mean, I have not had 2 months, let alone 2 years of Family Reach that have looked exactly the same. But that's what I really love about the organization. We learn, we adjust, we do something new. But yeah.
Thank you to both of you. Those are wonderful overviews of what's possible, as well as essential discussion of the complexity of what's happening here. Let's bring that to bear a little bit on a specific situation, because I know for me, hearing a specific situation can help me understand concepts a little bit better. And we had a wonderful anonymous question in the chat come in that can be a situation to show the power of what the two of you are each offering. And the specific question that has come in the chat is asking what resources or what process you might recommend to seek resources to help for people who are post-treatment, but have a mutation, so need continued care. And I think the subtext of this, of course, is once it's out of the urgent acute situation, it often can become harder for people to find support. So with your respective expertise, how would you approach the situation?
The need for better care coordination across different settings. And often, well, more often than not, our healthcare system is fragmented. So, someone leaves a hospital, for example, and goes home and then has all kinds of needs, but, that person's not getting the support they need. So I think, it's incumbent upon, for example, the people in the hospitals who are discharging patients to make sure that the right resources are put in place in the home and in the community that's needed. I think it's incumbent upon that person's healthcare provider, primary care physician, to make sure that he or she is coordinating the care that is needed. And as Chris said, this may be medical care, but it also might be other kinds of care that are so important to a patient's health and outcome. It may be related to food insecurity. It might be related to transportation. It might be related to mold in the home, that all have an impact on one's health. So what we haven't done a good job of in this country is making sure we have a healthcare system that's looking at this in a holistic fashion. That's where we need to get to.
Without a doubt. And so it is fruitful for the reminder, for sure, to say these things out loud, as difficult as it can be. The care environment, the clinical environment, is an okay place to say out loud to one's
Absolutely.
nurse practitioner, MD, navigator, whomever, hi, I am having a challenge with this. What do you suggest that can help me? And those simple 2 sentences can go a long way. I know they're hard to say out loud for everybody.
You have
myself
to start
included.
there. You have to start there.
Yeah, it's just such a challenge because it's more work of an emotional kind for people who are already doing so much work of various kinds to manage their diagnoses. Chris, what would you recommend in this situation if we think about someone with a mutation who needs post-treatment and continuous care?
Amy really did hit upon something I think is especially hard. I know something for me and my colleagues, which is to realize that it's important to leverage the experts and the folks who are like really on the ground for a lot of these families. When you have social workers or service providers who have been working with them directly, who are enmeshed and live in this community, it really is, as Amy said, incumbent to sort of hope that they are going to be able to navigate some of these next needed resources for families as they're leaving their place of care, as they're moving into their next phase of treatment. But it is also, I think, just an example of the difficulties of a system that is so bifurcated, that is really so you have many different organizations very specific on certain diagnoses, on places of treatment, on age. It gets really, really divided, and it can be hard. There's going to be places where folks slip through the cracks. And I think it's a great example of why at the end of the day, what our organizations do are essential. They're a big part of, I think, genuinely, as Amy said, saving lives. But what it's going to take to stop these instances where people slip through cracks, where there are places where there isn't that coverage, is broader systemic change that realizes that organizations like ours provide an essential service, but we're never going to be able to capture everything. And what is going to, the only thing that can really change that is that wider, significant systemic change that I think we're going to get to touch on a little later. So I know it's like it's frustrating, honestly, to have to admit, it's like that's a situation where, I would do everything I could to find resources through search and through what I know, but I may not know a lot about Missouri, and this family might be in Missouri, and I'll do everything I can to learn about it. But there's times when I'm not going to be able to do everything I wish I could, but hopefully I can at least create a space or find a way for these families or patients to have these conversations with folks on the ground with them, who will hopefully be greater experts in where they're living.
It sounds like then one of the summaries, Chris, if I'm understanding you correctly, is someone in this situation could reach out to Family Reach to benefit from that expertise of search. And so while we can't offer right now at this moment specific outcomes or resources, we can offer process and support, and to think about it, as you just said. Okay.
Absolutely. It's probably, unfortunately, we may not be able to provide like an emergency relief grant for this family, but I know if it was me or any of my other colleagues, they would hop on the phone and speak with them and hear where they're at right now, and also do whatever they can to find resources that can link them up for further support. Absolutely.
And similarly, all of us at Gryt Health are happy to support such as we can, which is admittedly going to look like a lot of searching and talking through the challenges, but that's what we're here for together in advocacy, no doubt about it. Related to that, though, Chris, as you were saying, and I'll start this prompt with you if I could, the complexity of the way that people with different lived experiences in different living situations really intersect so differently with the healthcare system. And so I'm curious if you wouldn't mind sharing a little bit about, because I know you're doing work in this area, what Family Reach is doing to support historically marginalized communities or people who have traditionally experienced access to care issues.
I'm so glad we are talking about this because it's something that is deeply important to me, when I first started as a social worker and before, and it's something I'm really glad and proud to say Family Reach is focusing on through some very important programs, which I'll get to mention. But sort of hitting on a theme I think I've been kind of touching on throughout the morning, I think it's important to just ground the conversation and understand why this issue in particular is so specific. So again, something I think about a lot that came up again sort of at the start of the pandemic, and it was just the sort of basic framing of things that I found really helpful for me, really grounding for me, which was to understand that the pandemic didn't necessarily break or destroy any of the systems we already had in place, but it exposed the extent to which things were already broken. And I think that when you look at the disproportionate effect cancer diagnoses have on families that come from historically marginalized communities, the same thing holds true. We see that Black and Brown communities or working class communities experience greater financial hardship during a cancer diagnosis because they were already living in systems that are failing them, that are intentionally not designed for those communities to thrive. So I think it's important for us to focus our efforts specifically on trying to reach and support those communities, and also to work towards systemic changes to prevent cancer from being so absolutely financially devastating for families in the first place. So I'm thinking specifically about what Family Reach is doing. Two things we've either been in the process of doing or are going to be rolling out even more significantly next year that I'm really excited and proud about from our organization are the Cancer Equity Initiative and Advocacy Collaborative. So CEI, Cancer Equity Initiative, is part of a Family Reach effort to specifically address the needs of Black and Latinx cancer patients and their families, to ensure that the work we do is appropriate to the needs of those communities, and that, most importantly, that this is informed by members of those communities themselves, and that we're able to work with other organizations that are sharing a similar mission, even if it's not specific necessarily to like one specific cancer diagnosis or one specific region or locality. And I will post a link to that, to this our webpage about CEI in a moment, but also to touch on Advocacy Collaborative, which I also think is really, really exciting and important. It's focused on us identifying and working with local sort of community-based organizations that are specifically focused on historically marginalized communities, which may have a smaller scope in their reach and in their sort of internal capacity, but it's an opportunity for us to leverage our size and our growth over several years, and the many resources and connections that we have with larger corporate or pharmaceutical partners to be able to expand their impact in their local communities. And I do think that is such an important part of how to engage in this work, is realize that as you're entering in, there are going to be folks on the ground who have already been engaging in this work long before you enter. So, it's important to understand your role is not necessarily to come in and say, well, now I know what to do and I'm going to start as if this is brand new, but to support the work that's already been going on there, to acknowledge that people have already put in that work, have made significant strides, know the community or the situation better. And often what they need is just material support. They need more folks who can handle cases and be able to do this outreach with families. They just need material support in terms of funding. So don't reinvent the wheel, or enter as if what you're doing is novel for this community, but do everything you can to support what they've already done. That is so important.
Without a doubt. And that's one of the ways collectively as the Advocacy Exchange and within everyone's own domains, we can help drive systemic change. And that's part of the humility with which all of us need to enter situations, because as you said, there are so often experts already. For example, the PAN Foundation is going on nearly 20 years of helping people get access to care. And across that history, Amy, which I'd love to hear you discuss in a little bit, you all have been thinking about policy and priorities. And specifically, there are a series of position papers on the PAN Foundation website. And I encourage everyone to look at those, because in any of our fellow advocates' specific domains, these are the kinds of position papers and policy thinking that each of us might want to borrow in our areas. So each of your advocacy groups may want to look at what the PAN Foundation is going, and Amy will describe in just 1 minute, about thinking about health equity and access issues. And so there's a lot we can learn from each other and the expertise that you have built up, Amy. And so I'd love to hear about how you see, there we go, your resources and what that looks like from the PAN Foundation.
When you think of what we do at the core, providing financial assistance, we are eliminating barriers for many. And this is especially true for people who have low income, but it is also very true for people of color who historically have had lower incomes than white individuals. And this fact actually came to bear in a poll that we just did a couple of weeks ago, where we asked people about the challenges. It was specifically adults on Medicare, but we asked them about their challenges affording their out-of-pocket costs. Of course, we found, that 3 out of 4 people were having challenges affording their out-of-pocket costs. But who were the individuals that expressed the greatest need? Black adults, Hispanic adults, people with low income, and people living with serious illnesses like cancer. So these are real everyday issues. One of the programs that we're very proud of at PAN is our transportation program. We launched it again a few years ago because we were concerned that it was presenting barriers in terms of people being able to get to their healthcare provider and get to their pharmacy to fill their prescriptions. So we provide additional assistance to people who are already receiving assistance. But we did one more thing because we're looking at care more holistically. We know that we want people to be able to put food on their tables. We know that we want people to remain active in their communities, and that might require some transportation. So we expanded the use of that grant to make sure that people could actually get to their grocery store to buy the food that they need. And interestingly, in the poll that we just did, far too many people said that they have already or will have to cut back on their food-related expenses because they can't afford the care that they need. So we all have to do a better job. What we're trying to do at PAN is screen people for additional needs, not just the financial assistance that they need for prescription medications, but do they have food insecurity needs? Do they have housing concerns? And try to connect them with the local resources that Chris talked about. It's hard work. It's really hard work and it takes time, but it's important. The other thing that we're trying to do is we need to reach more populations who need this help, who you said, Brad, have been historically marginalized. And one way to do that is by working with national provider organizations who see these populations every single day. So organizations like the National Medical Association, the National Association of Hispanic Nurses, the National Rural Health Association are important groups to collaborate with to make sure we're all reaching the people who have been underserved for far too long.
Regardless of one's geography, nationality, position, these things are the way forward. It is the only way to think about systemic change and equity. It's such a key area of advocacy where everyone's labors are absolutely essential because lived experiences vary so much. And it's the only way to make smarter policy is to do a lot of listening. And as I've heard you say in another context, Amy, just acknowledging that it's a long road to create change. But as you've said, it shows what can happen when you come together and collaborate.
Advocacy takes a village, and you can't have a short view on advocacy. This is a long road, and I'm particularly proud. Many patient advocacy organizations are proud that certain Medicare reforms were just passed as part of the Inflation Reduction Act in August. There are things like putting a Medicare Part D cap on prescription medications. So, for example, in 2025, no one will pay more than $2,000 for their prescription medications. That's progress. It took a while to get there, but it's progress. They'll be able to stretch out these payments throughout the year. That is also progress. So it is so important for all of us to not only advocate for our own healthcare, but to have a voice, because those patient voices, much more than PAN's voice, those patient voices make a difference. And if I have time, I just want to share one story which really speaks to the power of advocacy. We recently formed a patient and family advisory council for this purpose, to make sure that at PAN we were hearing the voices of patients to help us guide our own program development, but also, speak to policy changes that might be needed. One of the members on our council, his name is George, and I've used COL as an example. He happens to have, he's living with COL. And he also has family members who have lived and are living with cancer. And he has a grandson, Brewer, who he's worried that when he gets older and is an adult, he might be faced with cancer as well. So in our last meeting of the council, I posed the question, why are all of you engaged in advocacy? Why is this important to you? And George said, he put up a photo of his grandson Brewer, and he said, this is the Brewer effect. I want to make sure that the challenges that I am facing today are not experienced by generations to come. And that's the power of what we do. We want to make it a better world for all of us today, but we also need to think about the future. So I think all of us being advocates is really important.
And we hear that over and over, obviously, in advocacy work, which is everyone on this call. If you are here, you are an advocate, whether it's day 1 or decade 5, you are an advocate. And the way we get into this work is we want things to be better for future versions of ourselves.
Yep.
So we thank the both of you immensely for spending this time with us today and for sharing all of those resources, which again will come out in the follow-up email in specific, in addition to what you have seen in the chat, and will be on the advocacyexchange.com website. I thank all of you for attending today and being part of this conversation, the wonderful conversation going on in the chat, and the questions that help us bring things together in such essential ways. And I encourage everyone who's with us today to remember that while disclosure is hard, you can do it. And the people you're going to be asking in your clinical environments want to hear you and want to help. That's why they do it. I also would like to give immense gratitude to our 2 ASL interpreters today, because we have been talking very quickly with a lot of information, and they are knocking it out of the park. So immense gratitude, Mackenzie and Emily. Thank you very much for being here. For everyone else, we look forward to seeing you on the 1st of December for the next Advocacy Exchange session, if not on the website soon. And we look forward to sharing GVCC 22 resources with you once those videos are edited and compiled. So thank you all for being here and being part of our community. Thank you for making change, and we look forward to seeing you soon.